Thank you very much. Our next speaker is Jasmine Francis.
I thank the committee for the opportunity to speak. I have no financial relationships. 50% of people in America will develop cancer. The cancer death rate has fallen, but this means that many people in the United States will be maintained on cancer therapies, and these patients may walk into your office with a retinal problem. We know that traditional chemotherapy can be toxic to the retina, with the most common being macular edema of Taxols or the macular findings of tamoxifen. The newer ways of treating cancer include monoclonal antibodies and small molecule inhibitors, which can be identified by their MAB and IB suffix. The nomenclature can be more informative, but also more complex beyond that. I will discuss these class of drugs and their effects on the retina, and I'll touch on these 6 categories. We'll start with ALK inhibitors, which work upstream of the mTOR pathway. They are mainly used to treat lung cancer. And upwards of 70% of patients will have a visual disturbance which they describe as a trail of lights or an after image. This is more common in patients who are on crizotinib. The mechanism was thought to be due to the CNS, but newer evidence suggests that it's at the signaling of the retinal ganglion cell layer. These findings are mild, intermittent, and self-resolving. Moving on to BRAF inhibitors, which work upstream of the MAP kinase pathway. These are mainly used to treat thyroid cancer and melanoma. And almost 5% of patients will develop a bilateral anterior non-granulomatous uveitis, which can be associated with cystoid macular edema, and in rare instances, panuveitis, a VKH-like picture. It's thought to be due to inflammation to the apoptotic cells, and this can respond to steroids. Moving on to MEK inhibitors, also work upstream of the MAP kinase pathway, and these are used to treat GIST, gastrointestinal stromal tumor, ovarian cancer, and melanomas. And the toxicity here is a MEK-associated retinopathy and CRVO. MEK-associated retinopathy is bilateral subretinal foci of fluid that usually involve the fovea. The fluid accumulates between the interdigitation zone and the retinal pigment epithelium. You can see elongation of the EZ and the IZ, and as this resolves, these layers remain intact and hyperreflective, and there is no choroidal thickening. MEK is distinct from central serous chorioretinopathy. There are multiple fluid foci, and these foci do not have gravitational dependency and do not show the inferior gutting that we see in CSC. There are other ways in which MEK is distinct from CSC. The mechanism of MEK is largely unknown, but it's speculated to occur at the level of the retinal pigment epithelium, and these findings are intermittent, temporary, and reversible even when patients remain on drug. 0.5% of patients on MEK inhibition can develop a central retinal vein occlusion. This is thought to be due to oxidative stress, and this can result in visual rehabilitation, as shown here with anti-VEGF. Immunotherapy or checkpoint inhibitors, there are 3 different classes of these drugs: the CTLA4 inhibitor, the PD-1 inhibitor at the T cell receptor, and the PD-L1 receptor inhibitor at the tumor receptor. These are used to treat many different types of cancers, but predominantly these days, lung and melanoma. These drugs work by potentiating the T lymphocyte response against the tumor cells, which kills cancer, but also against normal tissue, which can result in inflammation. There are a number of findings of posterior segment inflammation, and there's much overlap and crossover between the different classes of checkpoint inhibitors, but there are also common shared findings between the 3 classes. Approximately 1% of patients will develop ocular inflammation, and this does respond to local or systemic steroids. Here are some manifestations of this: cystoid macular edema, uveal effusion, CNV, vasculitis, neuroretinitis, immune retinopathy, and AMN. There's also a VKH-like picture, which can be complete with neurological or skin findings. And I have discussed these different classes of drugs, and I would like to leave you with one word of caution, and that is that metastatic disease and drug toxicity can mask each other. Shown here, this is not immunotherapy vitritis. This is, in fact, intravitreous metastatic cutaneous melanoma. And shown here, this is not bilateral choroidal mets in the context of metastatic lung cancer, but is, in fact, immunotherapy-induced choroiditis. Thank you.